plenty of patient comes for my opinion. Some patient will come at the age of 50 years with critical left pain, right non-dominant or osteal right or 100% operated right. That is called unprotected left pain. Some patient come with osteoarthritis lesion. Some patient come with triple vessel disease in different age group. 65-year-old with triple vessel disease, long lesion in proximal arteries. And they always ask whether I should go for angioplasty or bypass. So which one is better? It is very difficult for all of us. As a physician, as a surgeon, as a cardiologist, everybody will have this dilemma what to offer. So to answer that, we have to see the overall picture, whether the LV function is good or not. Other systems like renal function, liver function, what are the risks, how long he is going to survive. That we know when we give opinion, we don't keep it in mind whether this patient look like he should survive for another 20-25 years or 15 years. And when you operate so much number of cases and after sizable years of practice, whatever your follow-up comes or some other patient's stent is there and it is flowing, some patient's stent is having instant stenosis, and then we need to go in and operate. Okay. So always there is a big question, and most of the patients require that, okay, I just want one procedure for my life. And that answer you still cannot give it in 2022. It's extremely difficult to understand patient psyche, patient body structure, his way of living, and what he wants. We don't ask patient relative or patient himself that what you want. Whether you want 20 years of good life without any procedure or you just need to go in and do that. So recently there was a exclusive coronary surgeons conference in Hyderabad, and one of my best friend, he presented the same presentation, and that's the reason that I thought that I should share with you. He gave this presentation in Hyderabad conference, and I requested him, should I present this same thing to our journal club? He said, you go ahead and do it, and if any question is there, please send me also to. So in this particular scenario, when we have diabetic stent and drug-eluting stent with polymer, thick one, and then the thin one, the newer generation, second generation drug-eluting stent, then the biodegradable stent, and CABGs with total arterial and beating heart and minimal imaging. All CABG started in 1960s, and now we are in 2022, almost 70 years. Still, first surgery was done with the SVG. Even now, 90% of the CABGs, almost every patient, 90% of the patient receives SVG in some form, either 1 gram or 2 gram or sometimes 3 gram. So every surgeon believes that SVG has got very good role, and it is not going to go anywhere from any surgeon's men to offer. So there is no single study which compare saphenous vein graft with the stent. That's a big problem. And now how to analyze that? Okay. So we have lack of studies. So how we can compare? So we have to see the survival data individually of stent as well as CABGs. What is MACE rates? Patency data from the other whatever individual review articles are there or research publication, and re-intervention rate. If you see then only you can compare whether saphenous vein graft is good or stent is good. So strategy one is you have to compare data of 5-year, 10-year, 15-year patency of SVT and 5-year, 10-year, 15-year patency of stent. Then only second strategy is the PCI versus CABG, extrapolate information from the study comparing CABG with PCI, not stent. CABG with particular SVG or Lima, no, CABG with PCI. Worst case scenario, assume the worst case scenario, all grafts are vein graft and it is blocked. First, if the graft failure in CABG arm was 10%, the vein occlusion rate cannot be more than 10% or greater than 10%. So that is the strategy 2. If you see this article in circulation in 2011, they stated at 10 years only about half of the saphenous vein graft are patent. And of those, only half are free of angiographic atherosclerosis. If you can see this, saphenous vein graft is a conduit used in the first series of coronary surgery. You have pointed. There are several reasons for this. The first, because of relatively large diameter and wall characteristics. It is technically easy to use. Second, it is plentiful. The length is there. Therefore, can be used to perform multiple grafts. It is a long, can reach any coronary artery, and fourth, it is easy to harvest. However, its durability and longevity is not ideal. This was in 2011. So, what this article says, at 1 year, 10 to 20% of the saphenous vein graft fails. Additionally, in 1 to 5 years, the 5 to 10% fail. And 6 to 10 years, an additional 20 to 25% fail. So, 10 years, only 50% of the saphenous vein graft are paid. And those, only half are free of angiographic atherosclerosis. Some form of atherosclerosis will be there, even if they are flowing. So, understanding saphenous vein patency, in this particular, they have clearly stated that this is the issue. 10 years, only about half of the saphenous vein graft are patent. It's a beautiful article, and this particular thing, the reference we have opened, this was in circulation 1979. Loss of improvement of angina between 1 to 7 years after aortocoronary bypass surgery, the correlation with the changes in the vein graft and in coronary arteries. To study this, the efficacy and safety of idofolates and E2F transcription factor decoy for prevention of vein graft failure following coronary artery graft surgery. What they found, SVG graft failure means stenosis greater than 75%, was seen in 29.1% cases at 1 to 1.5 years. Angiographic follow. This was in JAMA 2005. More than 58% in this particular series, more than 58% of the patient, the vein was harvested endoscopically. So normally in India, only few centers, जिनके 3-4 center हैं, they are only using endoscopic vein harvest. Otherwise, most surgeons, they just open it and harvest. This was an article by James Totulit's group, big people in coronary surgery, Fuller's, Buxton and James Totulit. And this was in Annals of Cardiothoracic Surgery. The right internal thoracic artery and the forgotten conduit. They have a series of almost 5,800 patients, and in that they had 991 patients angiography. And what they found, and this was a research article, and so number of years following surgery, the probability of graft patency percentage. If you see at 10 years, the LETA means left memory artery 91%, Rita almost 80%, right? Radial artery 78%, and SVG at 15 years it is 50, but at 10 years it is almost 80%. And this is one of the best research publication for all cardiothoracic surgery. There was another original research article, that is RAPCO trial, circulation, long-term result of RAPCO trial. Now what is RAPCO trial? This trial was basically radial artery patency clinical outcome. What they said, the RAPCO trial has reported an estimated patency of 71% at 10 years. This is for, in that radial artery patency group, there is another arm which was for SVG. And then they found that 71% patient at 10 years, the vein was patent. Now what about patency for the drug-eluting stent? The Lancet article, this was in which year? 2003, sirolimus eluting stent for treatment of patients with long atherosclerotic lesion in small coronary artery, double-blind randomized controlled trial, E-series. So what they found, the sirolimus eluting stent compared with controlled stent, 55.9% sirolimus group, and the other stent 42.3% at 8 months. Forget about other stent. Other stent is only 52.3%. Within 8 months, the patency is gone. Only this much is patent, means almost 60% patient is having either in-stent stenosis. And this is not any rubbish article. It is an original publication and proper drug-eluting stent company particular research. And these are big people in coronary coronary intervention, PTC. Same thing, in this original publication in 2003, 21% with the standard stent and 8.6% with the sirolimus eluting stent, follow-up of only 270 days. You don't have follow-up for 5 years, 10 years or 15 years. 270 days. And these are big people. Evaluation of coronary stent patency and in-stent restenosis with dual-core CT coronary angiography without heart rate control. Follow-up was only up to almost 3 years. 17 patients out of 48 stents had in-stent restenosis, 35.4%. New generation ultra thin drug-eluting stent versus older generation thickest drug-eluting stent for coronary artery disease. There is no difference in TLR between the stent. This is not surprising because trial with these stents shows similar angiographic rate luminal loss. So if you see this same article, the left ventricular mammary artery versus coronary stent impact on downstream coronary stenosis and the conduit patency. This is the conduit disease progression rate, and this is years. So this is basically internal mammary artery, this is a DES, and this is the bare metal stent. So you see after 1 year, within 1 year, the bare metal stent start having these stenosis, and then it gradually steep go up in 5 years. Similarly, drug-eluting stent for first couple of years, 3 years. After that, it starts climbing up. So the patency comes almost 50% at 5 years. Whereas Lima is still, it goes up. Now this article is not for weight, but this article or this particular slide is only to show that at 5 years, almost 50%, whether it is drug-eluting or whether bare metal stent, it is going to close or it is going to give trouble. Now, key point from these data, what we learn is limited patency data for DES we have. We don't have 5-year, 10-year, 15-year data. Patency for SVG at 10 years is around 70%. patency for stent at 7 years around 50%. So that we learn from these few original research articles. Now, does technique of vein graft harvesting matters? Yes, it do matters. Conventional technique like open the leg and harvest, endoscopic vein harvest technique, and no touch technique. Now, what is no touch technique? Without touching the vein or without touching the intima of the vein, you harvest. Or whenever you do endoscopy, somebody has to hold. So that part also you have to cut when you do the final stitching. So that whatever part which is touched by your forceps. So most of the surgeons, they use no touch technique. Another thing, when we harvest vein, we harvest in a long length and then we identify the area where there is no much wall or there is no wall. There are areas, if you harvest almost 50-20 centimeter of vein, there will be 7 or 6 centimeter vein which does not have any wall. So you have to use that wall. Your incision will be little more, but you have to use very smart way to have better SPG patency. Now, randomized trial on endoscopic and open vein harvesting for coronary artery bypass. Now, what happens? Vein usually harvested by either technician or assistant or junior surgeon. No senior surgeon will harvest the vein. Suppose if even now in our hospital, when I do surgery, I have opened the chest and harvest lima at the most radius. My assistant will be harvesting the vein graft. The thing is that the assistant should be permanent and he is doing the same job. My Siva Kumar Sarma, he is my perfusionist. He harvests vein. If you see him, even the smartest and the senior most surgeon cannot harvest that type of vein. Beautiful. When he harvests, absolutely beautiful without any touching the vein. Very just like artistic. So that type of thing should be there for all the units. Unfortunately, in most units it does not happen, and the people change, keep on changing, and then the patency of vein graft matters. The no-touch Sevenus vein for coronary artery bypass grafting maintain a patency after 16 years compared to the left internal thoracic artery for randomized trial. This was in JTC case. This is one of the big journal for cardiothoracic surgeon. So if you see at 18 months, the conventional technique and the no-touch technique, so single graft, means single vein graft was used, or vein was used as a sequential in 2 or 3 territories. If you see conventional, the patency is 89% and 90%, overall 89%, and no touch which is 95% at 18 months. Then at 8.5 years, the patency is 76%, where it is 90%. And at 16 years, 64%, and this is 83%. So almost in 80%, and even at 15 years, if it is no touch technique, your patency is going to go. Yes.
How you define patency after the procedure? What amount of diameter should be available?
It should not have more than 50% diameter loss. Now strategy 2, that is, we need to have information comparing the CABG and PCA, and assume that the all block grafts are vein graft. Thus, if the graft failure in CABG arm was 10%, the vein occlusion rate cannot be greater than 10%. So there was a meta-analysis of drug-eluting stent versus coronary artery bypass grafting in unprotected left main narrow. I already said what is unprotected left main. Whenever there is a right coronary artery is non-dominant, or right coronary artery is 100% occluded, or critical stenosis, and there is a left main, it is called unprotected left main. When right is flowing and there is a retrograde circulation, that means it is protected. So you do any intervention, no issue. Patient will tolerate. But if it is unprotected and you do anything in the left main, patient will have it. So in unprotected left main, the PCI associated with higher rate of repeat revascularization compared to coronary artery bypass. surgery. The percutaneous coronary intervention with drug-eluting stent versus coronary artery bypass grafting in patients with advanced chronic kidney disease. A systematic review and meta-analysis. In patients with CKD, the PCI is associated with higher risk of mortality, MI, and repeat revascularization compared with CABG and regardless of DAS generation, whether it is first generation DAS or second generation. The different RCTs, time period, 10 year, 12 year, 10 year, 5 year, 5 year, except for the Lehman's, there is no difference in reintervention rate. Otherwise, if you see in all, there is a significant higher risk of reintervention in PCA, all. And these are big trials, Syntax, Excel, Nobel, pre-combat. Finally, let us not forget size matters. Size too matters whether it is sex or surgery. Small target vessel size adversely affects graft potency. So, if you graft on a small size less than 1.5, this long-term patency after coronary artery bypass grafting effect of morphology and pathophysiological factors. Occlusion rate of SVG is 2.6 times more when it is anastomosed to less than 1.5 mm target vessel. Now, Indians have a smaller vessels like compared to European and American. When I used to operate in Dubai, almost all coronaries, wherever I open, it is more than 2. Here, whenever I open here, it hardly 1.5, 1.75 or 2. If you see my operation note, students, there will be size mentioned. Okay. If less than 1.25, we don't touch that artery at all. Whatever it is going, let it go. But so, for arterial graft, it is up to 1.25 mm you can go. So anything which is less than 1.5 mm, you have accidentally opened, you put arterial graft, it flow very nicely in that circulation. But vein graft, 2.5 times more occlusion. Drug-eluting stent versus uncoated stent for prevention of restenosis.
What is the size of venous saphenous vein diameter?
Saphenous vein diameter is 3 to 4 mm. And left internal memory artery is around 2 to 2.5 mm or 3 mm.
So does it make any difference that some segment is little larger and then the anastomosed native part is again
so
little
surgeon
smaller?
has to use his we have to develop in such a way that if it is large, so there are anastomotic techniques are there, how to use that conduit. If it is 2, sometimes it's 5, but we don't usually use more than 5, anything more than 5 mm vein in most of the patients. Before only we do a Doppler study and find out whether it is having varicosity or not.
What is the average length of graft we need to put in most of the cases?
It depends in which territory you want it to put. If you are putting on the last oil, then you require around 10 to 12 centimeter of graft. If you want to do a ramus intermediate or diagonal, you require 7 centimeter of graft. Or if you require a right coronary artery, you just require 7 to 8 centimeter. But if you want a PDA, so it depends. Again, it depends on the heart, how much it is dilated. The good LV function, the small heart, you require small length. When same patient with the big heart and LV dysfunction of 25% and the severe PAH, then you require it a longer one. So it is all depends on each and every patient in a different way. That is the reason. And normally we keep around 2 centimeters of extra length, so that even if patient develop later on LV dysfunction or severe PAH, the graft should not stretch. One of the reasons of graft occlusion is stretching of the graft. So 1 or 2 centimeter more is required. So and another thing is, sometimes when you do, first you do distal and then you do a proximal. And suddenly while doing the proximal, you find there is a wall there at the site of proximal. So you have to cut that. So normally what I give is around 3 to 4 centimeter extra. Whatever I feel, this is 7 centimeter, now I have to keep 7 plus 4. So around 3 to 4. So accidentally if I have to do re-anastomosis or redo, or after opening I find that there is a wall there, then I will cut that segment so that my patency will be better. So it is
Because
basically,
it is short by the stretching and the long by the પછી king at
no, it doesn't kick, but yes, longer the, see, basically,
stagnation.
that longer the segment, the chances of stenosis is high. So you have to use judiciously, बहुत लागू नहीं, बहुत बिल्कुल.
So
That
anything,
comes with the experience. When you operate more than 10,000 patients, then you know, okay, now this is the correct thing I have to do. Initial days we operate, just operate, and then after 3 years, 5 years, patient comes, and then we identify, oh, this can be a thing, this can be a thing. We go and review our previous angiography. This thought process always on when we keep on doing work. So after 8 months, in segment stenosis was 53.1% the patient receiving an uncoated stent and 9.8% in those receiving sirolimus drug-eluting stent in 8 months. The mean diameter of the treated segment was 2.2 mm. So these studies, most of the patients either having the proximal LAD or proximal RC or proximal circumflex. Not even a single study is second part of the coronary or third part of the coronary. Usually first part. And in that, within 8 months, almost 10% of whether it is drug-eluting or whether 53% of the non-drug-eluting stent. And the data is worse in biodegradable. You must be grown up. Long-term patency of saphenous vein graft and left internal memory artery grafting after CABG. The patency at 10 years in vessel greater than 2 mm in diameter, SVG patency is 88%, and versus 55% in vessel less than 2 mm. So vein graft we have to use in a particular target. Now, where the vein graft work fantastic. Vein graft base patency when you use as a graft to LAD. Second base is a diagonal, then the circumflex and the PD. The worst when it is used for grafting the main right coronary artery. Right main coronary artery you have grafted, the chances that within 5 years that graft will work. So,
CMI. Reason why
very good, sir. Good question. See, the right coronary artery, when there is a proximal block in the first part, the second part and third part. Second part usually there will be disease, and normally surgeon do anastomosis in the third part. Chopping after it is the most mobile part of the heart, right? Distal. After just before the bifurcation. Okay, that is called trigon area of the heart. Okay, from there PDA and PLB divides. There only there is a AV node artery. Okay. So that's all. So a right coronary artery normally it originates from the aorta, goes like C shape, the first part, second part, third part, and then it divides into two. Normally surgeon graft distal coronary, right main, on a third part of the coronary, because proximal part there is a block. So there is no question is doing anything in the first part. Second or third part usually they do. The third part is the most mobile part of the heart. So when there is too much mobility. Another thing is right coronary is having bigger diameter, 2.5, and usually it is heavily calcified. So my teacher used to say, don't touch right main. You have to do PDA or PL. So always he used to put a graft on a PDA. So PDA once you do, because PDA is the most important thing, vessel, because it supplies the posterior segment and inferior wall. So again, back to that slide, the Lima graft patency 91%, Rita graft patency 79%, SVG and right radial artery almost touching 80% at 10 years. Thank you so much. That's finished the presentation. Now.